Good afternoon. Calling us to order, and could we have a roll call, please?
Patty Becca.
Here.
Shay Louise O'Connor. Shay Louise O'Connor.
Dr. Bombard.
424 on a courtesy telephone to urgent.
Dr. Bryan. Dr. Clouser. Dr. Gerling.
Yep.
Dr. Cardo. Dr. Katz. Dr. Morgan. Dr. Pond.
Yes.
Dr. Richard.
Dr. Pond is here.
Dr. Pond is here.
In spirit.
Okay. Dr. Richard. Dr. St. Jean. Tammy Tromley. Dr. Ventry.
Here.
Dr. Viscardo. Dr. Weissman. Dr. Williams.
Here.
I guess Dr. Mulvey.
Here.
And I have Dr. Mariola. Anybody that I didn't call from REMAC.
Okay. We're going to open with Dr. Viola, who's going to tell us about the incoming World University Games.
So thank you guys for having me. I'll try to make this quick, but at least give you some hopefully helpful details. For some reason in Teams, when I try to share my full screen, it doesn't let me advance the slides. So if it's not too disruptive, I'll just leave it like this. But I'm a primary care sports med doc in Lake Placid, and I've been here for over 10 years now and been involved with a lot of events. The World University Games is going to be the biggest event that Lake Placid has seen. It will be here in January of 2023. It's the largest international collegiate winter sports competition. It's second in size only to the Olympics, and these games will be about twice the size of the number of athletes and delegation members we had for the 1980 Lake Placid Olympic Winter Games. So it's going to be, really a big undertaking. Some people in here have probably heard a little bit about these games. Patty is actually our EMS coordinator for these games. So her and I have been working closely on this and a bunch of other things for a while. There are 86 different medal events. We are expecting about 2,200 athletes and coaches. There will be 12 different sports that happen at 9 different venues in 3 main regions. And so I'll give you a little bit of that detail. They're predicting about 80,000 tickets sold. It's not really 80,000 individual people, but these numbers change and they're more marketing numbers than anything else. But there'll be about 600 different universities represented and 50 different countries represented in these games. The opening ceremonies are on January 12th and closing ceremonies are January 22nd. So we're in 3 months, these games will be over. The athletes villages open on January 7th. And so we are officially responsible for the medical care for the athletes, delegation members, volunteers, et cetera, as of that day. And then the villages close on the 24th. And afternoon on the 24th, we are no longer, as quote unquote, the games responsible for them. Most teams will come either on the 7th or just after the 7th, and most will leave before the 24th. But there might be a few either early arrivals or kind of stragglers on either end. The athlete training is, hockey starts the earliest on January 8th. Their games actually start the day before opening ceremonies, so on January 11th, and that's why they come here first. And then on these slides, it's really impossible to see, even if it was my full screen, but it's just basically a breakdown by day. The red are the finals in anything. And so it goes through, this is a second slide of, again, all the different sports, 12 different sports, and what day they're competing. The 3 regions, so One region is out in Canton and Potsdam. They will be playing the preliminary hockey games at 3 different arenas out there. And then there is a fourth on SUNY Potsdam, a village or really a college dorm room where all of those athletes will be staying. Sorry. In Lake Placid, almost all the sports will touch Lake Placid. The hockey semifinals and finals will move to Lake Placid on January 19th for the women and the 20th for the men. And then they'll play both of those games in Lake Placid and live here. Just those 4 teams. And then down at Gore Mountain, there will be ski and snowboard events that take place at Gore. And we have rented out the Great Escape Lodge and Water Park. So the athletes will live there in sort of a village, like dorm type situation. So we, as the organizing committee for the games, are responsible for coordinating all of the medical at the villages, at the venues, working with hospitals, our EMS systems, the Department of Health, kind of anything that could touch on medical. So at every venue, we have to have physicians, we have to have ambulances. We have athlete medical stations, spectator medical stations. Sometimes those are the same place. All of our ski and snowboard events require a helicopter in the region. It doesn't have to physically be on site at Whiteface or at Gore, but it has to be in that area.
Yeah, I have. But we're all done for a while. But I got the warm-up agreement set up. Yeah.
Here we go. At the athlete villages, so in Canton and Potsdam, there's a village. Down at Gore, there's a village, really just one place that all the athletes are going to be staying. But in the central region with Lake Placid, they're kind of going to be all over the place. So we'll have Paul Smith's College that about 500 athletes stay at. And then there'll also be different hotels throughout Lake Placid and Northwood School that athletes stay at. So we have a little bit of a different model for each of those areas. At the bigger, true villages, Paul Smith's College, Knowles Hall in Potsdam, and the Great Escape Lodge will have physicians on site, ambulances on site, and I'm already working with all of those hospitals to arrange, if somebody just needs an x-ray or just needs blood work, they can just be brought there, really trying to keep most of this out of our emergency rooms and off of our local health systems. In Lake Placid, because there are the most sports happening, the most number of venues, the most people that will be staying here, we really condensed our medical services to one place. We're calling it the main medical center. It will be at Lake Placid Sports Medicine, which is where the same building that the current Lake Placid emergency room stands in. And so any of the hotels that people are staying in around Lake Placid, if they need something, they can just come there. And again, the same thing is to really try to keep this out of our emergency room and out of our local health centers. So this is really just a picture of that. We do have lab and x-ray on site, which is helpful there. As most of you probably know, Adirondack Health put an application into the state to close the Lake Placid emergency room. And the state is reviewing that. The state will decide if it happens, when it happens. So I have no idea if it will be open or closed for these games. As long as the x-ray and the lab stay open, because we're bringing in private ambulances, I don't think it will really impact the care for these games. Obviously, that is just talking about these games. I completely understand the impact that this has on our EMS system as a whole, and it's a bad impact. But for these games, I think that we'll be okay. I've been reaching out and working with a lot of the different hospitals in the areas, going down to Albany Med, over to Burlington, down to Syracuse, which would be the level 1 trauma center for Canton and Potsdam. So I've been having monthly meetings with those hospitals, letting them know for the bigger level 1 trauma centers, this is really probably just business as usual. They're going to get the same multi-system trauma they would get any other day. It's more about kind of protecting our smaller hospitals that are really the local ones. And so again, the way that we're trying to do that, there are obviously going to be things that need to go to the emergency room, and that will happen. But then to be able to access things like lab and x-ray without going to the emergency room, hopefully that saves some of our hospitals. This is also impossible to read, but a little list of every venue and village and where we need to have ambulances. And so it's just a good outline to show you that we understand that these games completely overwhelm our EMS system before anything even starts. Because in Lake Placid, we have 3 ambulances when, you know, they're all working and staffed. And we have 5 different venues just in the Lake Placid region. So we couldn't possibly staff them only with local resources. I was really hoping that we could do that. But just for the duration of these games, that's impossible. We kind of get by for Ironman with 1 day of, you know, local and regional resources. But the state was not going to allow that to happen. We have to prove to them for our permit that we're not taking, you know, important resources away from the community. So we have contracted with GMR, which is AMR and CrowdRx. There's a bunch of different names, but basically they're going to bring in dedicated ambulances to cover all of these events. And then those ambulances will also be available, you know, if something happens at night, if our local resources are overwhelmed or just need help, they'll be available to help out with just the general 911 system if people want that. We have been working with the county emergency managers, county EMS, state EMS, and Patty and I and the state police, who is really running the emergency response. We met back in August with like basically any local or regional EMS company that wanted to be there, just to give them the same thing, an overview so that they understand what's happening. The key with a lot of this is that not everybody has a say in these games, including myself. So again, these games are happening over 4 different counties, and the New York State Police are taking over the 911 system for these games. And that is not my decision. That is not your decision. That was a state decision, and that is how it's happening. So we're, you know, doing our best to work with them and to kind of figure out, again, just how nothing gets missed, but we're not also having, you know, 3 different ambulances respond to the same call. Basically, the way we're doing that, just, you know, you guys are probably the ones that are interested more than anybody, but there's, for each venue and village, there is kind of a perimeter that's established by the state police. It's not an actual physical barrier, but, you know, just sort of the outlines of that facility. And if it is a games facility, that 911 call, it will come into the county, it will get dispatched to the state police headquarters in Raybrook, and then one of our games ambulances would be dispatched. If it's, you know, a car accident on Route 73, it's going to go through the normal 911 systems. And again, you know, I think there's going to be a lot of, Patty's going to be in the dispatch center at Raybrook with the state police. The GMR is going to have a dispatcher there as well. And so, you know, if Essex County needed assistance on something, it's as simple as, you know, a call to Patty, and we'll give you any resources that we possibly have that don't, you know, take everything away from the games. People, you know, we have been told that there is one emergency phone number to call, and that is 911. So the 911 system will still be used. Again, it's just going to be where that call gets dispatched after it hits the county. And there might be cases that, you know, it's possibly unknown. Is it a games venue? Is it not? And if 2 ambulances on occasion get dispatched, that's better than no ambulances getting dispatched. So we'd rather see, you know, a little bit of a duplication of efforts than missing anything. But again, the goal is to not overwhelm any of the local resources either. All of our volunteers on the medical side of things are volunteers. We have physicians, nurses, physical therapists, athletic trainers, some EMT volunteers, and you know, people are excited about these games and willing to take time off of their jobs and lives to come out here. This is a little breakdown, and if anybody wants these slides, I'm happy to share them. I just ask that you don't kind of publish it to the public. But we'll have about 200 medical volunteers and contractors, including the ambulance companies, that come just to help with these games. COVID, you know, you can't have a conversation about anything without COVID. We've been working with the county and the state Department of Health, obviously, on these. We will be following all, you know, federal, state, county guidelines. I've been, you know, following them week by week to see if anything changes. We are, right now, it's still required to be vaccinated to get into the country if you're not a citizen. So we're requiring all of our volunteers and athletes, delegation members to be vaccinated. Right now, the CDC is recommending against asymptomatic testing. So, you know, I think the next 2 months are going to be pretty critical in what happens with COVID. So we're just kind of watching it and waiting to see what happens. That's part of where I'm working with the hospitals. Obviously, anybody that's symptomatic is going to get tested. We also know that these are kids that are in college. They make bad decisions on a good day. So they're all going to lie about their symptoms. You know, and they're here long enough that people will get sick here. I have been following monkeypox for months. I've been following polio. Now Ebola is spreading in Africa. And so in Uganda, 2 of the US airports that they're putting in Ebola screening is JFK and Newark, which both of those will probably have people fly in for the games. We don't have any African countries participating in these games since they're winter games. But, you know, obviously we've seen with everything else that things spread now in ways they never did before. So we're hoping that Ebola is not a problem. And, you know, ultimately at the end of the day, if there are outbreaks, especially of something like Ebola, I mean, I would only imagine that the Department of Health would say these games are over. So hopefully that doesn't happen. There's been a lot of years that have gone into these games and a ton of money from the state. So we're hoping that they can safely happen. And that's kind of my broad overview. If anyone has any specific questions, I'm happy to take them. You know, this is my email. I'm also on the email invite for this meeting, just a Gmail account. So anybody feel free to reach out to me or to Patty. She's got a late class of 2023 address. Excellent. If there are any EMS agencies that don't know about these games, everybody, again, should be aware of them. We've met with them once. We're going to plan on holding another meeting probably later in November or early December would be my guess. We haven't really planned that out yet. But the state police is working with us on like the exact, you know, how things will get dispatched to what. And so we will host another meeting just to give them all the updates. A lot of the agencies had specific questions about what radios are being used. And again, that's all coming from the state police. So we can circle back on that. But thank you guys for having me. I appreciate it. I'm sure you have lots of things to talk about. So you're here.
Thank you, Teresa. Does anybody have questions for her?
Thank you guys.
You've never worked with Tracy at the Ironman? You should. It's really fun. She runs a great show. It's really cool.
Thank you.
I missed me this year. I was busy sneezing this year. I got COVID during the Ironman.
Not literally during.
I did not show it.
Right, right.
No, I
Ironman did not give her COVID.
That's true.
before that.
My friend gave me COVID. It was not the greatest gift I've ever been.
John,
All right.
you there?
Thank you. We need to approve our last meeting minutes. Motion to approve. Wait a second.
Made the motion.
Hey, how are you doing?
Dr. Ventry seconds. Any?
It's good. Just give me 1 second.
And any dissents from a vote to approve the last minutes? Great. I'd like to introduce Dr. Mulvey. Dr. Mulvey is the new Dr. Wiseman. She's representing a whole bunch of agencies down in the Elizabethtown, greater metropolitan area.
Hello.
Hi, welcome.
Hello. And I think we need to vote to approve Dr. Mulvey as the new Dr. Wiseman.
So we can move the item of new business with everybody's approval forward.
No,
I would
I was
entertain a
having nothing.
motion
I'm just trying
to welcome Dr. Mulvey to the membership.
I'll make the motion.
By Patty. Second?
Dr. Ventry seconds.
Yes.
Any decliners in?
So just, and nothing, this is not, just as a protocol thing. Previously, when we had entertained new members, we had an opportunity, if there was a discussion before we finalize a vote on an issue, right?
Let's do.
Which, and I don't feel like we need to in this case, but I think we should still have it just protocol wise be there. We would have the person actually kind of leave the room. Again, I don't think we need to, but I think we kind of ran into problems there on previous elections. I just want to make sure we continue that process going forward as a formal process, just in case there's any discussion that needs to happen before we do a approval and a vote. I have nothing to bring up in terms of discussion today, but just so we know protocol wise.
Yes, and usually after there's a second to a motion, then
Yep.
it's any further discussion,
Discussion,
and
yeah,
at that
yeah.
time you could ask.
Someone to leave the room, just in
Yeah.
case somebody has something they need to bring up, right?
Please keep doing that. Keep me in line.
Okay.
Get a little loosey-goosey in the interest. of
Perfect. No worries.
efficiency,
Yep.
And I
Okay.
probably shouldn't, really. So that's great. Thank you.
So
So any discussion?
I guess, well, if you wouldn't mind stepping out the room just for a moment, then if there's any, may just take 1 second, if there's any discussion or anybody needs to bring up something which we don't know about or what have you, right? Just so.
Don't go away though.
Don't get-
Yeah, don't go far.
Too long, but just in case, if there's any, so this way it just gives people free to kind of bring up anything discussion. I have no issues. Anybody have any issues?
Everybody?
Then I guess we can put it
No,
to
she was
vote.
pretty excited about doing this.
Okay,
Cool.
good, excellent.
And we got her resume out to everybody, correct? I wasn't watching because I kind of know what's in it.
I don't know if we did or not.
Let's make sure we do that.
So then I guess we can go with the vote.
Do we still have a pond? No, we don't. Lost our pond.
No,
Okay,
he's on there still.
is he still there?
Yeah, I'm sorry, I'm just trying to find the next.
Tom, you want to bring her back since you're over there?
Well, we should all vote.
Oh, let's vote.
Let's vote first.
Just kidding.
Just in case there's any, then people can head away.
All right,
Got a motion was second.
all in favor? Any opposed?
Yeah, so be it. Thank you.
Ah.
Yeah, cool. We're all set.
Come back.
We're good. Yeah.
I just want hiking for
Thanks for joining us.
Lot of that.
Okay, CMAC report. I really only have two big things. We had lots of like controversy at the CMAC that was really not pertinent to our region, so I'll leave that out. And Storm, jump in if there's anything you can think of that I'm missing. The two big things were unfortunately intubation is going away for AEMTs on the 1st of January 2023. So
In all scenarios, correct?
in all scenarios. AEMTs, no more intubation. And that's to bring them in line with the national standard curriculum. It's basically to make it easier on our educators so that we're at the same par with other states. So that is that. The other interesting thing, I guess statewide, but not, it doesn't change anything really for us regionally, is they approved aligning us with the American College of Surgeons Trauma Triage Guideline. And I just emailed out the link to that if anybody's interested, to Zach and Ann, and they'll get it out to everybody else, or put it in the minutes or both. But it's not going to change anything we do too much because we don't have trauma centers to choose from. Warren and Washington County folks, it may change things for a little bit, but I think you guys really have been following the same philosophy as those guidelines anyway, so I don't see it changing much for you either.
So just update on the process. The CMAC and the SEMSCO approved these. They then have to go to the commissioner for final approval. Once that we have that final approval, then the collaborative protocol group, hopefully we'll do better this time without having, COVID being a barrier. Will then ensure that education is done and that this is put out to everybody, hopefully in a much more timely manner than the last couple of updates that came out. So that's kind of the process. So while it's approved, it's not active yet until the Commissioner of Health approves it. And we get the blessing, which I'm going to guess would be maybe the December timeframe, if we are really, really lucky.
Did it change anything dramatically?
No.
I mean,
It
Why?
really doesn't.
okay,
It really
No.
doesn't. I think in the more metropolitan centers, it may.
Yeah.
But for us doing business,
okay.
I don't think it changes much.
And there,
And it might be more pertinent for you and Doug to keep an eye on it than for anybody else.
and
The rest of us are stuck in whatever.
we'll have to watch it too, because there's been some discussion over it, and I thought I had them here, but I don't. Some discussion over it because it didn't go through the CMAC first. Not the CMAC, excuse me, the staff, State
Oh.
Trauma Advisory Committee, sorry.
But
Too
it might
many
be hard
acronyms.
tax,
Oh, I do
so
have them here.
it's being-
If anybody'd like to see them, I do have a copy.
I can send it out to you.
Oh, yeah, we can send this out, but if you want to glance at it now. Let's pass that down. I can't make paper airplanes very well.
There's quite a bit of sentiment about changing our protocol process so that we actually approve them once a year. So we'll consider them throughout the year, and then ideally, the new protocols will be in effect every year on January 1st.
State program.
The collaboration,
Yeah.
same. So that'll be nice for everybody, right? You won't get ambushed with new protocols in August and November, and then a year goes by and whatnot. So that should be a good improvement. Pretty simple. And then Andy, you want to talk about the TXA and epistaxis updatey stuff?
Yes.
Awesome.
So we have created, TIF has created educational videos on epistaxis and on TXA. We've also done a memo that will go out following this meeting on TXA. So I had to do two memos because the North Country REMAC made some different decisions than the Mountain Lakes REMAC. We're hoping to limit that moving forward, but we'll manage that. So we'll have that memo going out to all the agencies. The training is posted up on our website. The epistaxis has already gone out. There is within our CME database. So if you've registered online for the CME database that we keep pushing out to agencies, you can go in and take a quiz and get a half-hour CME credit for that as well. So those will be, the TXA will be pushed out right after this meeting, but the epistaxis is already out there. Again, these are the protocols that were approved like before COVID and sat on the commissioner's desk for a couple of years. Then all of a sudden they got put out, and while we at the program agency level are waiting for the training videos, we discovered that since April, they've been on another region's website, and we didn't there was just a miscommunication because the state said, oh, well, we'll send you the training video when it's done. And apparently it was done, so. Moving forward, we're getting back to the process. Hopefully we'll get better at that process and getting communications out to our agencies.
Anne's got a great platform, and this is a great opportunity to get yourself registered for CME on the regional website. But both of these videos are super short. You have to listen to me, which is the downside, but the upside is they're, pardon?
They're good videos. We use them for class.
They're okay, good. They're, I think they're both well under 20 minutes. And so it's a good opportunity to get some CME and also get registered on the website, because going forward, we'll continue to post some education that's similar, especially when we do new protocol updates, but anything else that's germane to the region. And if any of you want to make videos to put on the website, that would be awesome as well. So that people aren't constantly listening to me, because that's just, it's okay once in a while, not all the time. I don't think I have anything else. Do you remember anything else we need to do? Anybody else have anything from CMAC that I missed? Everybody pays attention to it. Okay. Education reports. Storm.
Abby.
Patty.
So we had, I think, a really productive meeting prior to this one. As I'm sure people have heard, we are, trying to get things straightened away with the Ed Corp, the program agency and the council. I'm going to speak specifically about the program agency, the education, for sponsorship. So, we have, hopefully small issue with one of our courses that we already have a plan for. I don't really think that needs to come to this group, because it's not, at this point, we're hoping to get it squared away and it won't need to go any further. We are looking at the Dropbox. You're gonna hear this probably a lot today, that all the policies and procedures may be in. So I'm looking for the procedures for the Ed Corp. Once I get a look at those, I don't know where he went. Oh, where is he? Oh, okay, of course. Paul and I are going to bat that back and forth, I think, a little bit, and see what needs to be updated, and then bring it back to the Ed Corp and move that forward. One of the things we're seeing is we need to have some leadership with the education part of things for those that are doing courses for us. Paul has what's the word I want? Volunteered to do that for us as we try to move forward and figure some things out. So he will be the contact, and I'll help support him like I am with this Thai course on anything that might be coming up. As far as we know, and I'll confirm it for sure, our course sponsorship is still intact. Our specialty course sponsorship is not. We don't see it being a huge detriment to us because the specialty courses are going away. So for an example, the CIC courses really are going to be covered with NAMC. Okay. We approved Paul to go ahead and do a basic refresher course, probably in Fort Edward. CLI courses, we kind of have a plan to go forward with that. Again, with the help of North Country, the regional program agency. The equipment that's at Mountain Lakes office will be moved to Washington County along with the training files. Any older training files, correct, will be going to Clinton, or I'm sorry, will be going to. Yeah.
All of the page files that need to go and be kept on record will be a trouble.
So they can scan them up there, it can be done fairly quickly, and then we can mix those training files.
The equipment went where? I'm sorry, Shelley.
Washington.
I'm sorry?
The
Equipment
equipment.
is going to Washington County. your emergency services building, correct? Okay. The paramedic program has moved to Bay Ridge, and I'm sure Bruce could answer any questions if you have anything for that. Our office will be closing down there by the end of the week. One, it's hard to support at this time, and two, they want us out anyway because they found, renters that will pay higher rent. So I don't, what are you gonna do? Clinton County is doing fine. They've got a full, program for both basic courses and AEMT courses. North Country Community College, is planning on also a full schedule of courses. They will be teaching, courses in Malone, Saranac Lake. They're working with us. Help me out with that one. Akwesasne, there we go, that wasn't too bad. And, out of the Tide North Country Community College, campus. And we've had some discussions, about courses here locally, which we will, get you more information at a, when we meet again. Bay Ridge, gave a presentation on becoming a course sponsorship, which we made a motion to approve or to send us a support letter. Also, Paul will be meeting with the instructors in the southern part of the two counties. I'm sorry, we'll be talking to southern part of our region, Warren and Washington County, because right now there's definitely a need for courses and we need to have these basic EMT courses because we're running short, as everybody knows, and we need to also be able to feed paramedic programs. So that's really, really important. The last thing we talked about, which will come back to the next education committee meeting, is there's kind of a not an issue, but it's confusing for sure with Clinton Community College having their own preceptors, North Country having their own preceptors, Mountain Lakes having their own preceptors, and I'm missing somebody. Oh, yeah, okay. ECH having their own preceptors. So they're gonna get, to Zach, who will get out to all of us on the committee, what the preceptor program looks like, and we're gonna try to, if we need to tweak it or anything, so that if I'm on course or on preceptor for, Bruce's course, then yes, I can be a preceptor for anybody who rides with me from North Country Community College courses. So that'll be kind of exciting to get back on track with that. Am I missing anything from the education committee group?
So just for clarification and moving forward, it will be okay for us just to do education committee report and not list each education entity out on the REMAC.
Do what?
On the agenda, we listed each one out, but I should be able moving forward just to put education report, education committee report.
Okay.
If that's okay with everybody versus each entity giving a separate report. Remember, I'm still just trying to learn the ropes.
That's all I have.
Done to QA/QI.
Right, what else moving? Clinton County QA/QI. Clinton County QA/QI, you're on.
So we are still struggling with data collection. Ann's gonna try and see if she can mine some of it for me, as soon as I send her my data points that I want, but we're struggling through it, we're getting through, and I think that I will probably enlist, so I have some agencies that are very active and others that are not active at all. So we need to rein in those who are not active and get those active again. Probably get letters for their medical directors to get going, so we get their stuff collected. I had a question from a member who was sitting on a state committee, emailed me and said, do you have this data? And I said, nope, not there. So it is a problem. We don't, and we can't really address our issues if we don't know. We're still working. It's a work in progress every day.
ECH?
I know we've been on a little bit of a hiatus as well. Aaron Gordon, who's our coordinator, took a full-time job with the Glens Falls City Fire Department. He is still working on data collection, but he hasn't had a meeting with the organizations, since he began the academy stuff, so. But I'm still collecting data. I just don't have anything unless he submitted the report to you guys. I didn't think so. So, I don't have anything.
Right. Where do you go? Outside. Who are you working?
Yeah, we're still meeting actively quarterly and setting a report, so. I'm excited.
North Country, we're hoping to get reinfused here, with Dr. Brian. And Glens Falls.
Yeah, we kind of a few interesting cases recently. We reviewed a hyperthermia case from the marathon that went around Scroon Lake.
Mhm.
Yeah, so we got the guy there and reached out to people involved with that incident. Spoke to them about it, kind of a interesting case. And then hospital wise, we're working on kind of STEMI activations. From our cardiology group, they said that by having EMS call in and be more active and proactive in notifying us of STEMIs, we're cutting off like 20 minutes from door to balloon time. So it's been pretty impressive. So we're trying to push our agencies to call more earlier. We have options for them to kind of text pictures of the EKG when they don't have service for the LifeNet EKG thing. So yeah, we're setting up alternative options for them. The charge nurse has a cell phone, and then any of our providers should, allow them to text in as well. So yeah, it's kind of it so far.
On that, I'm going to spring from that note. We got off the agenda for 1 second, just to remind everybody that CUPH, also the other cath lab center, has a physician carried cell phone now. So if you don't have that number, I will make sure to send it out with the meeting recap. But that's important, and it's taking, certainly just anonymize your EKGs and send them on in, and that way we can activate early.
Are they using the secure messaging through that?
It may at some point. I'm working with IT to see if we can like hook it into Haiku and do it that way.
Yeah.
But in the meantime, it's at least a step.
Yeah.
Because we were doing really badly in sending and receiving EKGs, and now it's cell phone technology. So if you can get a cell, and I understand that, but if you can send it, and it's easy. So.
Is there a specific number for the Glens Falls?
For the
Because like when I come in from Newcomb, I try to send it while I got coverage, because then I don't have coverage
yeah,
for a long time.
yeah, I can tell you charge nurse. The Glens Falls charge nurse number is 518-223-5132. That cell phone's always at the charge nurse desk.
Awesome, thank you.
Awesome. I will send that out as well. Great. All right. And off to Ann for program agency reports.
Guys, something a little different you're probably not used to, but I actually, if I can find my file, you have just a quick little PowerPoint here. And of course I lost it. I had it pulled up.
If that's the UPH number, is that still the 6776?
I can tell you in a second.
But both numbers are really just a text, to be clear, right?
For the charge nurse, you can call me, it's a cell phone, so
Okay.
you can talk to us, if they call med control, sometimes we don't pick up or we're on the other line, so
Okay,
they can talk to the nurse and speak to somebody through that, but yeah, I mean, primarily want to see text, pictures come through there, and then.
okay.
59367.
And we're trying to make sure that you text first and then call, because otherwise we're waiting for something that we don't know. If they call us and tell us about something, we don't have anything in front of us to see. It's a little bit more difficult, but if they can text first, and then that kind of streamlines the process.
Same with ours. Patty, you can call it, you can text it. We've got people sending photos of car accidents and all sorts of.
Get that screen back.
It's been cool. The docs, to be very candid, are not fantastic at carrying it, but the more we use it, the more they'll start carrying. You know, they're gonna get excited about it once it keeps going on.
It won't let me move the screen.
I apologize that they're naughty, but trying. And again, you know, the more cool stuff we send to the phone, the more the docs are gonna wanna carry the phone. So it'll, you know, it's a, if you build it, they will come kind of thing.
All right, that won't let me open it all the way, so you can see it. There we go.
Now move it over.
It won't let me move it over there. Now it's going to let me move it over. Sorry. So I'm gonna slideshow here. I did it, yeah, go. All right. So this is just a quick report. I did attend, whoops, the last RTAC meeting. Is this the right one?
No.
Sorry. That's not the right presentation. But I did attend the last RTAC meeting. I will make sure, where is it, Zach? We got two copies
Yeah,
of this
that one-
going,
that one
so
there, yeah.
we had two copies of this going.
Yeah.
I'll get this smoothed out, so it'll work better next time. Oh, where's the slideshow? Here we go from beginning. Okay. Now let's try that again. All right, so again, here is our contact information, and I'm sure everybody's seen it 100 times. This program will be included with the notes, so if anybody does need our contact, it's out there. We did hire a new clinical coordinator. Her name is Jessica Thompson, and she's just getting her feet wet. So we look forward to working with her and her being able to do some quality assurance and some help with some of this data collection, et cetera, as we move forward. Again, we did start a paperwork at fdrhpo.org email address because many were very familiar with sending it to the Mountain Lakes, paperwork to the Mountain Lakes email address. So I'm going to just touch on the conflict of interest form and the whistleblower form. So if you're a member of the committee, Zach has sent those to you. Please make sure that you get those back to us. The bylaws and the REMSCO deliverables are for the next meeting. I only did one PowerPoint, so we won't worry too much about those. We had these on the agenda too, so we're going to be talking later about the Wadsworth blood glucometry, unless you want me to go ahead and talk about that now. So the limited laboratory license for all the EMS agencies in the Mountain Lakes area is not active. I have reached out to the Wadsworth lab a couple of times without response. There has been some discussion that they weren't going to do a limited lab with.
What does that mean?
It means they can do blood glucose.
The can or can't?
They can, but in
Okay.
order to do blood glucose, you have to have a limited lab license from Wadsworth Lab.
Okay, all right.
So sorry, I
Okay,
apologize. I
that's
didn't
right.
realize you didn't know that. So we're working on that issue right now because it was set that it was Mountain Lakes with each entity being a location underneath. So anyhow, that's not active right now. So we are working on that.
So what does that mean for the agencies?
It means you don't have a limited lab, so you shouldn't be doing glucometry, but again,
We're not gonna do that.
Yeah.
Exactly.
Okay.
Well, when the license comes, we'll,
Yeah.
yeah, but we didn't say that formally, but,
yes,
right, I
as
understand.
we, hopefully we can get this resolved.
Yeah, okay.
I don't think it matters that we do say it formally.
Yeah,
Of course we
it's
do.
fine.
Otherwise,
Yeah,
each
exactly.
agency will
Right.
have to go out and get their own limited laboratory license, which costs $200 every 2 years. And unless they're fully volunteer with no staff members, then they can get a waiver of that $200 if they submit specific paperwork. And it only covers transport ambulances, not first response. So. Okay, and we will,
What
so,
happens if you don't have a license? I mean, what?
Yeah.
What repercussions are there? Should you be operating without one of these work
state.
license?
you could get a statement of deficiency or
Okay.
fine from New York State.
I see.
What's that?
It would, you would get a fine, it would be along the lines of price, and that's a license.
So Ann, do you have a list of all of the agencies that fell under that? Because I thought that Clinton County, some of our agencies went out on their own and got their own licenses.
I have nothing. But I did, you can search on the website, so there is a few agencies that I found, but I've not had time to search out every Mountain Lakes agency. I do know that this, what we find, Plattsburgh City Fire had one.
Okay, Morrison Doe should have one.
I didn't,
Yeah, we'll have to look. We'll look.
I can search them if you know who it is.
Look at all our agencies.
I'm again trying to figure
Ideally,
out.
this should be a regional thing, right?
Right,
Like
exactly.
every
It's just
agency
they
should
need to
not
do it.
have to
Right,
pay
exactly.
attention to this.
They may not allow us to.
Well, let's
We're
try.
gonna try.
We'll keep on
It's well
going
worth trying.
until we.
Maybe if we're
absolutely-
troublesome enough, they'll just say yes to make it go away.
I do like that.
This is
Until then, we'll just assume it's going through business as usual.
Yeah, absolutely.
Perfect,
You
okay.
know, This is,
Yep.
we can't bar our providers from using a device that's available at Rite Aid.
Right,
This is just foolish,
right.
right? It's fastidious.
Yes, exactly.
So,
Yes. All right, so this is the proposed meeting schedule for next year that went out. Again, this would have to be approved by REMSCO. So once it is finalized, I will send it back out along with meeting invites for that.
Our REMAC meeting schedule, or this is?
both, yep.
Both so the REMAC and the REMSCO meet the same days, so once this is validated through the REMSCO, then I will send it out again to both email lists.
So if you have I'll send those out as well, but if you have conflicts, now's the time.
So again, Dr. Malve, welcome. Keene Valley's already submitted the paperwork to DOH for a change in medical director. We need to work on getting the rest of those done. We have had 2 agencies, actually I had a second one the other night that brought up putting together a committee and looking at RSI, pre-hospitally. So I just threw that on the agenda. We'll throw that till the end, because I'm sure there'll be further discussion on that, if that's okay.
Plenty of discussion on that.
So we'll throw that to the
Okay.
end. I'll finish my report. We'll finish moving through. All right, so I did attend the September 12th RTAC through Albany Medical Center. There was a lot of concerns about pre-hospital care reports getting to where they should be. On behalf of the agencies, I said, there hasn't been a lot of education. The state's directive on how to do this doesn't make sense to most because they are transporting these folks to a landing zone to hitch a ride with a helicopter to the trauma centers. So the ambulance destination, for the most part, is that landing zone. not the level 1 trauma center. Or, the receiving facility when they send them via air medical. So there's been a lot of concerns about them documenting Albany Medical Center as being their receiving entity versus the aircraft. So we've been working through that, and we will continue to work through that as when the state does a data update here fairly soon. I do believe that they will be changing the fields for documentation of such. So again, it's been a tough for our agencies as well. Bunch of new policy statements out there from the Department of Health. I'm going to specifically talk to the 2211 Health Commerce System one in a moment. But there's the discussion on your outbreak of Ebola, passenger restraining devices, and vaccinator guidance policy for EMS. So the health commerce system, they are moving forward with the ability for EMS providers to print their cards digitally. This system does not work at this point because the health commerce system and PROD, which is the data system that the Department of Health work uses, 20-year-old systems need to talk to each other and match the DMV system. So none of it's matching. We've been unable to facilitate this. We've had multiple calls with Health Commerce System and the Bureau of EMS to no avail. Although each agency, I can get an administrator in for each agency in Mountain Lake. So we are your HCS coordinator, your contact, Zach or I can do that, but we haven't had much luck otherwise getting things moved forward. So we continue to work on that. Again, we're still looking for pediatric emergency care coordinators to help champion pediatric care in the agencies. So feel free to push that out to your agencies and reach out to us if they're interested. There's the whole protocol updates and education. So the links will already all be in there with the training. And again, we're asking all our agencies to establish a CME manager for their agency and get registered in the account. But training, we will be doing our annual conference in Alexandria Bay on the North Country side. We were having a billing documentation conference that ended up getting canceled due to lack of signups. We paid a lot of money for a fantastic speaker. She's willing to postpone it, but it's how agencies can maximize revenue through their documentation. And again, good documentation is going to help their clinical practice as well. And then we are doing some leadership planning with the AHEX or the Health Education Center. So we need to report the PAD stuff. So there it is.
Can you go back to,
Whoops,
no, the pad?
sorry.
On top of spring fling, is there any intention on maintaining the initial assessment conference?
At this time, there's no finances to maintain the initial assessment conference.
Would you like to run a conference?
But
Anyone?
if anybody would like
If
to,
anyone wants to pick up
run
this
it,
charge, I think we can. We need somebody enthusiastic that wants to make this happen. I think it's make happenable.
so
Innovation.
I don't know that, I think that right now, things have to be, get back on track and then go revisit it. So it may have to take a year off. So Zach, do you want to add anything on here?
No, we did some of the numbers on the trauma fluid report to make sure we weren't overloading patients, and they looked pretty good initially. I think now we're working on IV access. One Jessica's working on.
Yeah, so, I'm sorry, I thought you wanted
Oh,
to,
sorry, I mean.
to
there's
do that
nothing
when
new.
I can talk
just
to that
that
one.
That runs monthly, go, I send it naturally.
okay,
That's an easy one.
okay. So we did pull data on the trauma calls, so basically out of the EPCR, the data, and I could pull this all up and look at it, but quite frankly, when all was done and said, there's so many variances in the way people document. We only pulled like a very few number of major trauma calls since the beginning of the year in the Mountain Lakes area. And when I say a few, less than 10, pretty sure that's not a correct number. And then we turn around and we pulled data based on just venous access without fluid administration and got a much larger number of charts. So we found discrepancies in the amount of fluid, like they received fluid and it was only documented in the narrative, or the amount of fluid put in the box was the size bag that they had hung. And there was a lesser amount of fluid actually administered in the narrative. So there's definitely needs to be some education on ensuring that you're documenting vascular access and you're documenting the amount of fluid actually given to the patient. There was only like out of all the charts that we looked at, there was like a very small amount where they actually gave up to 2 liters. One said 3 liters, but the narrative didn't support what they put in, so we're pretty sure that was a data entry error. But there was only like 2 or 3 charts that actually had up to 2 liters of fluid. The rest were much smaller amounts.
This is a notoriously difficult piece to evaluate, right? We have the same problem in every hospital for sepsis is trying to document the accurate amount of fluid given. It's virtually impossible. I think we kind of struggle with getting good data to make any process improvement if we're looking at that as an initiative, just because of the difficulty getting accurate data.
Is there a field in PCR, IPCR and EMS charts to clearly say how much fluid was given?
Well, so you have multiple PCR vendors
Right.
around the region, but they all dump data into an image trend
Right.
state thing.
Right.
So we're pulling data. So
Right.
the interesting thing is we found better data coming out of the north, because we're not going to do 1 and 1, we're going to do it in the other region. But North Country data dumps into a different data bridge and then goes to the state's bridge, and we found better data in ours. But I think it's the way the system's set up.
Yeah.
So we're trying to figure that out. We have a big question for the state on why did this pull out of the central light, but not out of your state light site?
Yeah. So on the individual vendors, EMS charts and IPCR, there are fields where you can document and it'll cross over through the bridge, right? Like,
I
this
believe
isn't.
so, but I'm not going to put money on that.
Exactly,
There should be, and then they all kind of have them phrased differently, and then they just get mapped to the one specific field in the state grid.
Okay.
So they might have different wordings around it,
So but if we tell our agencies they need to document volumes, there should be a field in the charting where they can put in that number and not just write it somewhere in the
Correct.
narrative
That
or
should be
God knows where.
a fill-in field, yeah.
So the thing that, anything they can document in a drop down, we can then pull
Right.
data on.
I use the IPCR system when there is not, you can pick like, you were gonna give a 250 cc bolus, but there's no place for
Right,
volume infused.
Okay.
right.
And I also use trauma soft, and there's not, you can say you gave a bolus of 250. So however many times you did, but there's no place but total volume infused. So you'd have to write it in your narrative, and those two. I have not used the other.
See, this is our problem. I mean, if we had one vendor,
Right.
I want to write that down. So it's what, Trauma Soft and IPCR?
So if there's no place, how are you gonna get that data then? You just have to read each chart, each IPCR chart? Okay,
Yeah, and that's even with a clinical coordinator, probably not a happening thing.
right.
Just you know, just to get and I finally stopped her. I said, you gotta stop. You can dig into this as deep as you want. You got crap data.
Yeah.
Crap information. I can't report this to them and have it, you know.
Some of it too is documenting other fields. So like one of the reports that we ran, part of the criteria was, your trauma center criteria, which I think there's like 9 or so many options. So if they didn't pick that as an option, they could null for trauma center criteria, even though it meant that per se, you know, could be provider knowledge, that wouldn't have pulled that report. So our initial fluid report only came up with so many results. When we filtered out some of our criteria a little bit, we got more results kind of a thing. So we need to know like specifically what we're evaluating, I guess, kind of thing, but also providers need to be trying to, I guess, fill in as many of the pick options as they can. 'Cause that's where we're really pulling our reports and data from.
You know,
I mean, agencies can set it up so some of the fields the providers don't even see in the PCR and they're just automatically populated. So that's an issue too. It is kind of nice where we do, well, we only have a handful of software vendors, so I mean, we can get some knowledge out there if we know specifically like what we want from people, but.
and again, there's no way we can be familiar with every
Right.
system.
Yeah.
Which is, you know, back in the day, if they'd actually just facilitated one system and not spent all the money printing paper PCRs, we'd be much further ahead. But that's
So
another story.
this is a perfect example of what we need to be able to do for QA/QI, because, you know, in the past, we really didn't have this information and then take back to the agencies to say, okay, let's pick a topic and let's take it back. I mean, we looked at Aspen one time, remember that? So
Well, we can to some extent, but I don't have a lot of faith in some of the data. I think I threw it on here somewhere. I actually have a lot on here. So we are also actually, you know, actively, I'm actively on the state QA/QI committee, and we're working on some regular, pulled it off into that. Sorry, too many files. You know, just to give you an idea, and I mean, she did a great job, but the farther, you know, it took a long, long time. Only to say, you know, we have terrible, terrible data.
So the springboard for this conversation was in our protocols. The trauma hypotension stuff says normal saline to a total of 2 liters if there is no concern for pulmonary edema, and then consider norepinephrine if needed after the fluid bolus is completed. So no norepi until you get to 2 liters in case of trauma. And I'd love to know what your guys, I know what my opinions about this are. I don't know what yours are. Feel like
Well,
2 liters is too much? Do you feel like
yeah,
2
I don't-
liters is enough? How do you feel about this?
Yeah, I certainly don't think you need to wait until you get to 2 liters to give norepi. I mean, obviously in trauma, you know, fluid's not what they need
Right.
in reality. So,
And norepi isn't either, but until
no,
we have blood product.
yeah, I think it has to be a kind of a combination of the two. I don't know if I have an idea of a specific volume to give. You know, obviously, you know, we allow permissive hypotension. You have to assess cognitive status and other factors, but you know, I certainly would push for more of a balance between norepi and fluids rather than just 2 liters and then norepi. I don't think it's a binary option like that.
So this is kind of what we came up with. So basically, a total of 20 charts were reviewed, and those 20 charts were pulled based on data. So we want a major trauma patient. So in order to get a major trauma patient, and you know, 3 of the charts were reviews from Mountain Lakes, 17 from North Country. But in order to get to a major trauma patient, right, we have to pick all of these fields in the EPCR. So they had to meet one of those, not each one, but one of those items which is the major trauma criteria, and that it was a 911 response. And that normal saline was documented, so. Again, this is a whole data and informatics thing on the back end, and then we just have to go around, so. Again, most of them were traffic accidents, there was a fall. So pretty much the normal saline fluid administration. So the blue represents greater than or equal to 500 milliliters. The orange, the darker orange is equal to 500 milliliters. Less than or equal to 250 is the gray area. And then the 5% there, the provider documented fluid administration in micrograms versus milligrams, so that's an error in units administered.
I don't know, I weigh all my fluids before I administer them, micrograms and milligrams of fluid.
Very little.
Yeah.
Per milliliter, sorry.
You have to adjust it out
Micrograms.
eventually, but yeah.
Yeah,
Is it
Sorry.
something that you guys want me to take to the protocols to ask them to change? And if so, in what way?
In terms of the 2 liters and the
In
noise.
terms of the 2 liters,
I agree, there has to be some, I mean, I don't really do trauma, but I'm saying there has to be a clinical judgment. If
Yeah.
the patient is clearly, if you appears to be in pulmonary already, you probably don't want to push the full 2 liters.
Yeah.
And if you got a blood pressure problem that's not initially responding to fluids, you have to go to norepi.
I think the threshold for norepi should be lower, consider after a liter or even lower than that. I mean, I think the wording should definitely say that it's not 2 liters, then norepi. What the exact volume is, I don't know, but I certainly think that whatever it is, it should be provider judgment plus, a kind of a mix and match, a little bit of fluid, a little bit of norepi. I think that's probably better than flooding them with fluids, washing out their factors, diluting whatever's left, and then giving norepi to try to salvage. Yeah, exactly.
Right.
Catch up to
meanwhile,
whatever you
the
just
poor
did.
little platelets are like, I'm over here.
Yeah. Yeah. Yeah, exactly.
so reviewing norepi charts, because I do not believe it's given that often,
No.
would be a much easier task than trying to do fluid administration. So we can look at norepinephrine charts if we have any.
Springboard. The other thing I wanted to ask you guys is, do you guys have opinions about lactated ringers versus normal saline? Do you want me to, if so, do you want me to bring that forward? Nobody cares?
Yeah, I,
Don't care.
Yeah.
Or don't care? I don't care.
No.
I'll say-
Is everybody carrying LR?
No, nobody's carrying alarm.
Yeah. So,
No, and I think I brought that up once to the
And there's
collaborative
lots of
group.
discussion about LR versus NS in the EMS community, given that the pH of NS is 5.5.
Yeah.
And that the people that we're giving NS to in large quantities are acidotic to begin with. So there's a lot of academic discussion that goes along with this. But you guys are the leaders of your
this has
agency.
been going
and
back
if
and
you're
forth for
feeling
years
like
and
we're
there's
not getting
no
enough to make a
definitive answer.
difference.
So to change based on nothing definitive.
lots of academic opinions. not
Exactly.
lot
Not a lot of good
opinions.
data. Yeah.
So I leave that alone. If you think of anything else that you want me to bring forward, please tell me, because I'm happy to do that. I sit on the protocol committee, and so it's easy for me to like take that in and funnel it. And then, as we do that, we can then look at our data and see if we're changing appropriately with our new protocols, right? So I think that would be a nicer way to run QA. Obviously, we're always going to do cases in QA, but it would be nice to see, if we decide to change something, whether we're changing it, what the rapid rate is, all of that. Sorry, I stole the show there for a
No,
second.
that's all right. This stuff is more specific to REMSCO, so I was just kind of flipping through.
Yeah, don't put the docs through the REMSCO stuff. So.
Next, state EMS meetings are the 6th and 7th, and we were at the last ones. And again, I am on the state quality metrics tag because of all this stuff, so. And that's it for any questions for the program agency, and I just threw the renewals up on the slide so that they were just up there.
We usually go through the renewals quickly, agency by agency. We don't have to beleaguer this, but
So the, are these all listed, Zach, as,
Yeah, so the first one is, West Florida Fire, they were just doing a BLS FR agency update. I think they're Dr. Williams.
That's on hold because they're having, a difficult time getting, sponsorship with an ALS agency for QA and other, training. So right now that's on hold.
Mariah? Mariah? I never say that right. More, I never say that right.
Franklin County one, right?
Yeah, Moira.
Yeah,
Their BLS agency update, all their stuff was in there. I don't think there's anything.
Who's their doctor?
Richards.
Dr. Richard.
There's no issue.
Glens Falls.
I'll do all my three, Glens Falls, Granville, and Salem. No problems, all excellent agencies. They can all be approved.
So then what, Fletcher Allen was Dr. Clouser, all of that is also in the folder, he signed everything, so they are good. We kind of talked about them a little bit when we did, UBM's the month, or they're at our last meeting, but they were up and so they submitted all their stuff.
Of Owl's Head and Saranac Lake.
Yep, we did get a bunch of the stuff back from Owl's Head. The only thing that we still needed was the MD signature form. Saranac Lake, we received everything back. I got the doctor's signature form this morning, actually while we were here. So the Saranac Lake is all set. Northern is all set. Shady sent in a couple of their paperwork over the weekend, but they're still missing the MD signature form. And City of Plattsburgh, I haven't heard anything back from them.
we signed their stuff yesterday, so we should get it.
So basically, everything, I guess it's your guys' discretion on the Owl's Head one, because we don't have the MD signature form, which would normally be the forwarded motion. So we could do an extension for that one if you wanted to. The other ones are all set, but Shazy, Plattsburgh, and then up to you guys for Owl's Head would be for 3-month extension for our next meeting. And then the other ones can just be the regular standard 2-year renewals.
So Owl's Head will need to get bumped to next meeting. On the
Yeah, we can do
extension.
that as an
Yeah,
extension,
yeah,
yeah.
we can't approve that now.
So I guess the 2 years would be Moira, Glens Falls, Fletcher Allen, Granville, Salem, Saranac Lake, and Northern.
I'll make a motion to approve.
Second.
All in favor, or sorry, discussion? All in favor? Any opposed?
And then 3-month extension, or until our next meeting, it might be a little more than 3 months, because I think we're doing February instead of January. But the extension will be for then Owl's Head, Shazy, Fire, and Plattsburgh.
Make a motion to approve again.
Second.
Discussion? All in favor? Any opposed?
And then, so going forward from there, you go to the next slide again. The next agencies that are gonna be coming up soon, which we already talked about, the 2 extensions, which we just talked about for Shady and Plattsburgh. Bangor, which we received already the state paperwork for, we're just waiting on the Mountain Lake signature form stuff. Bay Ridge is up at the end of November, Easton Greenwich also the end of November. Ticonderoga, North Country Lake Plate are the end of the year. And so that's pretty much it, which those ones will all just be at our next
Was
meeting.
there one in Plattsburgh?
What was that? I'm sorry.
Was there one in Plattsburgh?
Plattsburgh City Fire, which is,
They
It's
have
got the
sent in the
extension.
districts and-
Yeah.
Yep.
Yep.
Shady.
So the other one, at the last meeting, North Queensbury, you guys did an extension on because you weren't sure on what was going to be taking place with the merger.
Okay, actually, so let's do another extension since there's been no information, and they're gonna come up with Bay Ridge because that's who they're merging with, and it looks like that comes up for renewal in November. So let's, if it's okay with people, shall we table the?
I think our extension will last.
We'll
till
cut
then,
until it's
so-
perfect, okay.
Yeah, that's what I was just gonna say, because they knew we had somebody here if there was any questions. I did speak with them and they are
Okay.
going to be, just kind of be absorbed under Bay
Bay Ridge.
Ridge.
Okay, yep. Okay, well, good.
So. All right.
That's pretty much it. Back to agenda wise, conflict of interest and whistleblower, we kind of already talked about him a little bit. I think the whistleblower is a new one for most people. We haven't had that one yet.
Is that going out, the whistleblower one?
No, we were gonna talk about it show it at the meeting. and then
Oh, okay.
send it out. It might have went out in the meeting materials for today.
We have
So-
paper forms that we can just sign off on those?
I can send them out to you. I think we have
Oh,
to
okay.
adopt it or approve it.
I see the whistleblower, we have to adopt as a policy. I
Yeah.
see, gotcha.
Yeah, so that'll be, the reps go will hopefully be
I
adopting
see,
that as a
gotcha.
policy, but the
Okay.
conflict of interest we have to have.
Yep.
And again, those are rules that we just have to make sure that we have them. So minimum equipment list, which was already sent out. So the minimum equipment list, I put it in here and I just lost it. So it does, the REMACs are supposed to have kind of a minimum equipment list. And I don't know if you've ever had one in the Mountain Lakes area. We've always had one in the North Country because it assists our agencies in making sure that they have all the appropriate supplies to meet each protocol. And it also helps, especially with supplies being so outrageous, for them to, maybe pare down some of the things that they carry because they may think they need to carry them, but they can actually, run any protocol in the ambulance with the minimum amount and then add additional quantities if needed based on their clinical demographics, for example, if, you're running in a city that has a high number of overdoses, you may carry more Narcan than an ambulance that runs in an area that does not. And it gives new agency leaders kind of a guideline, helps ensure that we have everything we need on the ambulances to treat the patients and kind of gives a standard like the Part 800 gives for BLS ambulances of what they should be carrying.
And the minimum equipment includes medication?
Correct. So I did send that out to everybody. Just gotta find the file again here. Yeah, I know, I knocked myself out of that folder. There we go. So the only change that we would have, there's a couple changes that we'd have to make to this to make it fit the current Mountain Lakes practice. And that would be TXA and Afrin to be made regular medications where they're optional on this one. If it'll let me pull it down, here we go. All right, so there's the medications and they are for each level of care, AEMT, EMTCC ambulances or paramedic ambulances, or there's no X if it's not required under that level of care. So these are just your standard medications, and then there's a recommended additional supply, but they do not have to have that on there. That just kind of helps them with their storeroom So all the protocol medications are on there. And again, we know that some manufacturers, we're looking for it in some form, preferably pre-measured, right? Because that decreases errors out in the field or pre-filled. But sometimes they may not be able to get that due to manufacturer shortages. So, as long as they have, the amount, for example, the naloxone, it is approved by the Bureau of EMS that they can carry the nasal Narcan that's, 0, or that's 4, what is it, 0.4?
4.
It's 4 milligrams in 0.1 milliliter fluid or something like that. So as long as they're carrying the comparable amount. Narcotics, those are based on, they're required for LCC, and paramedic ambulance, and what they carry is truly based on their plan. And they don't have to carry fentanyl or ketamine. They need to have, Versed and morphine. So optional medications, these are ones, based from the protocols. And this is where, oops. This is where we would have to remove, TXA and Afrin and move that into a required med. North Country left them as optional for ambulances to carry, but here as far as I know, we're expecting our CMP or our paramedic ambulances to carry it. So again, those are all just optional
Why are acetaminophen and ibuprofen optional?
because they're optional. Whether agencies want to carry them. It can be moved. Not all.
Is there a non-optional option as well? Is there like a different formulation in the mandatories, or is it optional only?
No, I think they're optional. The protocols, are they not? I have to look. I believe they're optional in the protocols, but it's up to, the region can make them mandatory or not.
When are we moving TXA and Afrin to the mandatory list?
How about today?
Well, before I put it out, I mean, it's not, this is a standard list. I'll move it before it gets put out if that's the.
Yeah, if we're gonna disperse this to agencies, when do they need to have that stock by, I guess is the question.
To be, the protocol is Tylenol and ibuprofen are if equipped and trained Asterix.
Yes, that's why they're optional. Thank you.
Seems like it's time.
Oh, I agree with you.
Yeah.
You know what?
So, Tylenol and ibuprofen.
Yeah.
Are, if equipped and trained
Right.
medications, it seems like we should just equip and train. Like, let's put those on our.
On the other hand, it's like,
This is
A,
crazy.
these are non-emergent medications. B, if you're calling an ambulance because you need a Tylenol, you should be without the Tylenol. That's the other side, but.
And when we
Yeah.
have to purchase them, we can't purchase a smaller volume. We have to purchase like,
Yeah.
I don't know, what is
So
it?
it's a cost saving thing.
Yeah.
Reuse that we throw away.
Right.
I would say simplify, simplify, simplify. We don't need it.
Yeah.
Yeah, and so again, that's, some agencies choose to carry it, some don't, so that's why we
Leaving it
kept it optional. But the TXA and the Afrin, we can move, but I do believe in the protocol, they're both equipped and trained as well. So we will move those.
Did we approve it as mandatory? Is that?
TXA is to be required.
It's gonna be required? Okay.
That, it's come up before. I don't know, did we ever vote on making it mandatory? Or do we need to vote?
Remember if we voted
I can't
on
remember now.
that?
Yeah.
We talked about the
Voted to
training, that's what we
approve for the
voted on,
region.
and whether we made it, there was some other element to it, but considering this is another one where the literature is kind of leaning away from great benefit, anyhow, that's, again, for further discussion in terms of whether we make it mandatory or optional.
I guess my understanding was that you're gonna have it on, but I don't know that an official vote was. I know that in the North Country, they talked about it and said, we're gonna make it optional.
Yeah.
For those ambulances that wanna carry it, they need to notify us with, work with their medical director and notify us if they're carrying it, because we talked about this at the last meeting.
Yeah, that was my understanding of where things were at, even for for us. as
And
well.
I'm fine with that. I have not put anything out. I'm just trying to look up the shock protocol quick like now.
I don't think the protocol says if equipped and trained, I think it just says do.
There's an asterisk after it. It's just, it says see educational document, which I don't know,
No,
an education document.
It does not have an asterisk next to it.
It does in this one. Which app are you in?
I'm looking at both.
Huh?
I'm looking at both of them.
Use of TXA in an EMS region must be approved by the corresponding regional trauma advisory committee, which is the first time they've ever done that with a protocol.
But it was, so that's
And it
done.
was, whereas in the North Country, the RTAC was not for or against it, so that's why the
Yeah, I mean, so
That is
Yeah, it
right now,
doesn't say optional in the protocol, so. we
so
should
right
probably
now
put
we
it
have that approved to use, but not mandatory, which,
Not mandatory to carry.
right. Yeah,
Right.
so if you want to
Yeah.
use it, I mean, if you're in an area where you see a high volume of epistaxis, then maybe it's.
And are we distinguishing between using it for epistaxis versus using it for trauma?
Oh, yeah, I guess yeah.
That's
I
two
don't
different
think it's in the
indications.
epistaxis
Yeah.
protocol. to my knowledge.
epistaxis protocol.
It's epistaxis, not for trauma.
It is for trauma.
It is for
So
trauma.
we're
through and
talking
through. Okay,
about
so this is,
Afrin.
yeah, okay.
After-
I was,
Wait a minute.
Sorry.
I was on TXA.
Yes,
I was still on TXA.
yes, that's what I mean. So again, trauma indication versus epistaxis indication.
Yes, TXA is for trauma, decompensated shock.
Gotcha, okay, I thought we were,
Okay.
I was lumping these together, epistaxis, so,
Okay,
yeah, TXA for trauma,
Okay.
I do like.
Yeah.
Certainly not for epistaxis, but,
It's not in the epistaxis.
okay.
no.
So, okay, I see that's highlighted with an
Yeah.
oxymetalloline, which is why I was kind of linking.
Well,
these two.
because
Okay.
it's two different meds, two different
Neither of them
protocols.
is mandatory.
Okay, I was confused, that's.
So for TXA,
Yeah.
TXA
for
for
trauma.
trauma.
In trauma,
should we make that mandatory?
How expensive is it?
It's $11 per.
yeah, it's not expensive.
Yeah, I mean, trauma seems to be the only place where TXA does seem to benefit, so I have no problem making it mandatory there.
Until we run into crash 4.
Well, yeah,
We'll see
at the
how
moment,
that
it seems
goes,
that,
but-
Yeah, right.
everything else is steady.
And it's for paramedic level ambulances.
there's-
So paramedic level ambulance, and we,
And are we doing the bolus and the drip, or is this just the bolus?
Just the
It
bolus,
is,
just the
I
bolus.
think just the bolus makes sense.
Yeah, because the drip,
I just want to make sure that we
In 1 gram.
understand.
Well, they're putting 1 gram in 100 milliliters over 10 minutes.
So it's
Yeah,
1
Yeah,
gram.
bolus, yeah.
I mean, yeah, I think that it make that mandatory. If it's $11 per dose, you carry one on your rig. I don't think that's too much of a financial burden, and, more than likely you'll, at some point, I mean, everybody sees enough trauma that, we could justify using it.
It's to have
Probably
more
gonna
indication
dilute.
than some of the other medications we use. That
Yeah,
that way,
exactly.
so.
Probably
it's,
gonna
you know,
dilute
it's
the
reasonable.
efficacy overall but with that, but.
Yeah, I think it's reasonable. And
Yeah.
do we need a certain amount of time frame for them to implement this?
Yeah.
To get it, 6 months, a year?
Yeah.
I don't know, but
Yeah,
October,
we're in October now. Yeah, I
we
don't
get
know.
them done by January 1st.
are there any difficulties getting new medications up on board?
So it's training, ordering,
It's training and-
delivery,
right.
that sort of thing. Okay.
And it's only a paramedic unit, right?
Can you get next day delivery on it?
Depends on the
So
day.
when you buy it, it comes in a box of 10,
There we go.
so you have to buy the box of 10. I guess you won't be able to get them individually.
Oh, so that's
So
a,
that's-
So that is-
Comes like that.
that adds to the cost.
Yeah,
So if I have
So
one,
in our system, it won't be a problem because we have a vending system that'll expensive, but for
Let's follow
the
my beat.
world of those people who are buying this, when they may use
Put it
it
in the
once every
Texas.
5,
Well,
that's $100 cost.
it's been a problem. It's the same thing with like glucagon and things, which they,
there's a federal law
yeah,
that
yeah,
requires them be bought or sold in lots.
right.
So they can't break the lots up. So if
Right.
I'm an ambulance that needs one, I have to buy
You
a
have to buy the
whole
whole lot.
lot. And I can't give it to my friend ambulance down the
Yeah.
road because I can get in all kinds of trouble for that.
Can the county, can the county?
You
coordinator
cannot
help
do
with
that
Is
unless
that
you're a
part of the county
dispensary
coordinator's
for the law.
Yeah, it's like, whose DA license you want to put it under is the big question. That's,
County's more than
It's-
happy, like, I'm more than happy to let my county buy stuff under my
yeah, I mean,
license.
like-
I'm comfortable with TXA distribution.
yeah, yeah, it's,
There are worse things under my license
no, no,
than
sure,
that.
look, I get it.
I said this daily recently, and it seems like Albany Med Pharmacy is purchasing meds and allowing.
Yeah.
And the agencies can go through them, so. In
It's
situations
a little
like,
again, it has been
Yeah.
addressed at Glens
Yeah.
Falls, but yeah, okay.
so potentially Glens Falls might be able to take on that role as well. Who knows, we'll see. But,
Potentially.
but that, I guess, yeah, the volume thing is gonna be the.
Okay.
I mean, we
So,
certainly- like, my agency has certainly bought things from the CBPH pharmacy.
Ours won't let
As a
us do it.
single
Yeah, our
Because they don't
pharmacy-
have a distribution
Exactly, that's the
license.
same as ours. They will
Yeah.
not let us buy, they will not let agencies buy in bulk through our pharmacy at the hospital. That's been tried and done.
Hmm.
Yeah. It's unfortunate.
It does seem like our
interpretation
county
of,
coordinators might be part of the answer,
Maybe,
but they're gonna need your license to do it.
But they can't distribute it.
But
They
again,
can't distribute it after they buy it, that's.
on the other hand, it's still a lot cheaper than like glucagon or something, for instance, right?
Yeah. So we'll get on this outrageous.
What's the shelf life of TXA? Do you know how long it lasts?
I don't know what the shelf life is, so probably about a year, that's what most of the drugs are.
Oh.
Most of the drugs that I purchase.
I think this is probably, it's still, it's minimal compared to some of the other meds we use. It's probably, we've got bigger.
So
items to-
TXA is,
yeah.
just so I'm clear, TXA is going to go in the everybody have it list.
would you like to make a motion?
Well, we'd make a motion,
So we're
I think
all-
it's reasonable, but
Yeah, I mean, I guess, do we need to look at whether it's financially, I mean, I don't know,
well, bring it up.
I
You
think
make a
we-
motion, you make a motion, I'll second a motion, other discussion, then we can talk about, it. I mean, it's not, I mean, so box of 10, $110, I mean, in the grand scheme of things, agencies feel free to jump in here. This is not expensive medication, even buying it in bulk compared to some of the other
Yeah.
questionable stuff we're buying.
Yeah.
And this has some benefit.
yeah, if you're
As
paying
opposed to-
$110
yeah,
a year.
yeah.
Okay.
Yeah, so, all right,
Okay.
any other discussion?
Something specific for education.
So we've done the video and we have a quiz out there, so
So
they
that's
should
out there.
keep, those are all done.
Okay, yeah.
There's the policy, which I'll make sure fits whatever.
Yeah.
And just had a chance to look at, kind of what I wrote up about it. We just wanted to make sure everything was in order here.
And does it
Before
need
we-
any storage? Like, does it need to be kept at a certain temperature?
No.
Okay. So it's not onerous to just throw it on an ambulance and have it there, okay.
And then what, we give people 6 months? Is that reasonable? 6 months to
January 1st, just to make it nice and clean.
January 1st,
It's not
okay,
that-
January 1st,
Yeah.
Sound okay?
barring any unforeseen circumstances.
And if it's,
I don't
if
think
it's
the
a back,
TXA police are gonna come after anybody.
Yeah.
if it's a back order by the distributor.
Then so be it, then it's not, it's
It's
out of our
claimable,
control.
yeah.
Yeah. Okay.
So what about the Afrin?
Um,
So let's do the tranexamic first, as a
Oh.
separate, since we're doing this for trauma.
Okay,
All right, so we've got a motion, so make a vote.
all for it?
Yeah, favor.
I'll go,
Any against?
perfect. Then, we'll go to nosebleeds, all right. Okay.
Get a price for you for that. I happen to know the
and I
other.
mean, it's, if equipped and trained, again, I would just leave it
Yep.
optional, so. Part of that is because you can't, it's not a multi-use bottle, so
Yeah, right.
unless you can buy the little ones, you're buying the, it just seems like a lot of waste.
Yeah.
But,
Well, I always just give it to the patient, to take home.
yeah,
and send them to the hospital. Hopefully they don't have to come back. Yeah, I
so,
mean, how much is, after? Is it-
It is, let's see. At Walmart, it's $6.48.
But,
Yeah.
so we have to make a box of 20.
At Rite Aid, it's $10.49.
now I think you could go buy that over the counter and
CVS, $10.29.
Yeah.
I would go
not
to.
worry about that federal law that makes them sell on the lots.
I think, well,
$6.48 at Walmart.
yeah, it's not expensive. I don't think the price is the issue. I just think what is the efficacy?
Pick it up on your way.
Even gasoline. Yeah, right.
Yeah, I mean, I use Afrin, I mean, I think it works reasonably well, just as good as anything else, so.
It
I don't know.
lets us leave a couple nosebleeds at home because we're doing
Yeah.
practice. I see.
Yeah. How much of those clips, can we just give those clips that you mentioned?
Yeah.
Right. Clips
I
of,
usually just palm a few of
probably
those
the
clips
benefit,
out.
right?
Yeah.
With the spraying.
Yeah,
whatever,
yeah, exactly.
Right, yeah.
They get allocated.
It's fine. It's not an unreasonable medication. to
Yeah.
have, You know, yeah.
So you want to move it to the required.
Yeah. Same thing, started January 1st.
Yeah.
Easy
So,
enough.
Same motion in second.
Same
Yeah.
motion, I'll second, discussion, favor.
All in favor?
Any
Any opposed?
Okay,
Awesome.
Good.
Is there anything
Okay.
else you guys want to move up to the mandatory list? Tetracaine,
Negative.
Morgan loans is, what's that last thing? 51, I can't read that.
Potable water?
Bottled water, so if you are carrying any of the tabs or whatever, you actually have something for the patient to take it with.
Since the tabs are optional, we can have the water as optional.
Yes.
Yeah.
So then this just goes through your, normal sailing, right? You should have 1,000 bag. The remainder should be in whatever, 100 milliliter bag for, med administration.
Sorry, these are the required list of?
Yeah,
okay.
the minimum is the first row. Again, you can always carry more.
Yeah.
But just to ensure, the one thing that we did just recently remove in the North Country that I did not remove here, but we pulled data. And, most charting systems all have the gauge IV catheter. Nobody's used a 14 gauge catheter
Yeah.
forever. Is anybody here used a 14 gauge for anything other than a needle chest decompression?
Yeah, I was
when you
gonna say this.
When you should have a 3-inch needle versus
Yeah.
a 1 and whatever it is. So we removed 14 gauge catheters.
Captains or agencies, is there stuff on there we should take out, which the medical directors may not be familiar with?
I have a question about the, it's on the next page though, the spare monitor cables is a requirement, they're like $600.
But if you cut through a pair, then you're out of business until
Unless you've got another ambulance, then you can swap
Unless
it.
you can swap them.
Yeah.
$10.
Yeah,
Same as
Yeah,
your monitor can
right.
break two and you're out of control, but if it's 600, then I guess.
Yeah, at least, that was the last time I
Yeah.
priced it. It was
Yeah.
last-
Do they have to be on the
Because we
ambulance?
came back at the station.
Yeah. I think one
We had
spare
lots of
set.
friends on the way to the
There
hospital.
you go. That's something which can be, I'm okay with.
Yeah.
I mean, they could be, I think they've just been there forever,
Yeah.
just because
Yeah.
of that, they get cut frequently.
Hopefully hopefully not at $600 now. Right.
Yeah.
Exactly.
Well, usually it's once they get to the hospital, so.
That's right, yeah.
With new, new staff not paying attention.
Be fast with the hand slip.
And they've been on there for so long that they probably were $100 when they've been on there,
Yeah.
were put on this list.
I'm fine with taking that off.
Yeah.
Anything else that jumps out on these lists that?
So again, you still need the needle chest decompression,
Yeah.
14 gauge.
Yeah. Yeah.
The atomizer, you need it if you're gonna, you don't have the other, but then your blades and all your tubes.
Yeah.
Size 9, we removed a while ago because nobody's using a 9.
It's a
Technically,
good suction catheter.
AEP thing, but all the innovation stuff should come off that level, right?
Yeah.
It will when it comes out, yeah. So I update these as protocols change. Secondary airway needs, I had to remove it because protocols don't allow pediatric secondary airways for AEMT. CCMP, yes, so that's why that's highlighted, that'll come out of there. But anyhow.
Wait.
Change the term on that?
Yeah.
Secondary airway device, I mean,
This is generic.
Well, that's not, see, I'm
Probably
not saying
super
King or
broad.
LMA or anything like that, but I'm just saying versus calling it a secondary airway. I mean, there's some agencies that are using it as primary airway, and there's some cases where it should be the primary airway.
That's fine, but that's a clinical judgment. On the list, you have your intubation stuff.
Right.
Could we call it a supraglottic
Supraglottic
airway?
airway.
That way we're actually defining what we meant.
Insertion device or something.
Yeah, that would be a good change.
No,
Sorry.
I know, I'm maintaining a totally separate.
Good point, though. Clarity's good.
Sure, we'll put supraglottic airway in there.
Thank you.
Now, the reason under you'll see like defib combo pad. And as you notice that is because an AEMT unit may only have AEDs on them. So that's why they're both listed there. The AED and the AED pads for the AEMT units only. Believe it or not, many of our ambulances did not have neonate BBM or neonate masks on them. So that was something that, because it's not a Part 800 requirement, that's something that we added in.
Do you require any spare monitor cable?
No,
Take it off.
and again, RSI medications are only where it's approved, they would come off the Mountain Lakes one. And again, fly cars are, required to carry. Dial flow or gravity IV set should be done, training should be done per the manufacturer's recommendations.
Take the dial flow out.
I believe it's in your protocols. That's why it's there. I don't disagree with you
The
whatsoever.
very few pieces of equipment more useless than a dial flow. Okay.
Again, there's just some recommendation to have them portable so you can take to your patients. So it used to be a much more extensive list. We just recently cut it way back.
What does it mean when it says fly cars and transport ambulances are minimally required to carry what's on the required list?
Well, because actually the statement can probably go, it used to be a minimum required list that would be in the portable bag.
Mhm.
And then a required ambulance on board stock. And we just changed it, so that statement should probably go away.
Which is confusing.
It is. It wasn't confusing in the previous context, but it is now that I look at it.
Okay.
So the fly car could be not necessarily it could be an AEMT fly car or a BLS fly car, correct?
So this is only advanced AEMT and above. BLS fly cars covered under EASD or Part 800
Right.
requirements. So this is only AEMT or above. And then they should have the minimum list. 'Cause we used to have a minimum and that we wanted carried in a portable bag to make sure it went to the patient. And then an onboard supply.
Yeah, I get that, but quite frankly, some of us, based on our call volume, closest to the hospital, like and I've got the state permission to do this, I found out we're literally gonna cut back one of our rigs to an AEMT ambulance because like, Adrian is saying, we're just throwing out tons of medications. And when we're on a really tight budget, every little bit definitely helps, so that's why I'm saying.
And that's fine. I mean, you can have a BLS ambulance and then I ran with a commercial company that you had to sign out your narcotics from Safe on the Wall. Because that's where our narcotic plan was written, and then pick up your ALS bags. And when you got on that ambulance, it now was an ALS ambulance. So you had all your meds in that portable bag and all your equipment in that portable bag.
We're just throwing out so much stuff that,
That's why we had been trying to, keep whittling this down, but again, it gives guidance to new agency leaders on what should be on the ambulance and what they need to meet each protocol. So. Any other questions on this? So I would, entertain a motion to approve this with the changes of removing the supraglottic airway, or changing, not remove. Change the wording of secondary to supraglottic. TXA to mandatory. Afrin to mandatory. And, I'll remove that last line.
And remove the 14 gauge IV
Removing
needle
14 gauge.
and the extra monitor.
And the extra one, yep.
I
So,
have it written in like 3 different.
so fly cars are what? Fly cars. are-
They,
So if you're removing the 14 gauge, was there something in there for thoracic decompression?
there is,
Yeah.
there was 14 gauge, 3
Yeah,
inch,
3 inch.
You need the 3.5 inch versus just the.
Or 3.5.
Small.
right there, 3.25.
Yeah, that's fine.
Yep.
I'll make a motion to approve.
Second.
All in favor?
Yeah.
Any opposed?
And this will go out for like the January 1st with everything else.
Sounds good.
so, I'm sorry, but will this go out?
Jan 1.
When I go out, it'll go out
This week.
within the next 2 weeks.
It's on this list is protocol book.
I'll put protocol book /app. You should have protocols
Yeah,
available,
we should have
right?
access to protocols, but the protocol book might be outdated. If we just do a print.
Yes, we did it as late as we know.
A lot of people print them, but now most people use the app, so that's just a change in technology.
Is the Mural app, MURU up to date?
As far as I know,
Okay.
there is an error on the collaborative app with the TXA, which has been sent to be fixed. It
I
says
thought there was an
AMT
error
can
on the
give it.
Muru for it as well. They were both. all-
Apparently, apparently you have to update it, so if TXA is not sure, I had to
Oh, is that?
I had to go through a whole bunch of crap to get mine to update.
I thought they weren't supporting the your collaborative protocol app. I thought that's why the Muru app.
So Maru came out, but we chose because a lot of our providers, so we're financing. There's a bunch of us that are financing the other protocol app to stay up and running, so
Indefinitely or?
as long as we can, as long as program agencies exist, when they go away, then you're all on your own.
There are problems with the Muru app. We can talk about that later.
Okay.
I was looking at TXA and, Apple are on their collaborative protocol, right?
They're not on it, formulary or? Not
They're in
on
the
it?
protocols. They may not be in the formulary, but they're in the
I know,
protocols.
I couldn't find out.
Do you have an epistaxis protocol in yours? Are you Android
Yeah.
or
Android.
uninstall and reinstall with an Android?
For the,
Some of them updated automatically, some did not.
The TXA is under trauma associated shock.
Shock.
So that helps you.
And
Because I'm
there,
looking at it in the collaborative.
there is an error on that one. We are aware of that. It is paramedic only. And again, if it's a CC on that paramedic rig and they want to use it, they're trained in it, they can call it.
I have Apple on epistaxis on the Android protocols app.
Yeah.
Is it on the
reinstall?
If you don't have an update,
Yeah, and what do they have?
mine updated, but I have an iOS. And again, I think this is just a lot, you know, we put changes out there when we know that app's updated, we'll put memos out to agencies and say, you know, here's what you gotta do if you're iOS or if you're Android, if it doesn't work, call us, we'll troubleshoot it. But we do have the fix into the developer, Tim Morabito, whatever his name is there, was going to. I can never pronounce it right.
Probably.
Yes, was going to ensure that once he confirmed what level of care that was, to have that fixed.
And are they updating the protocols because for the shock and the TXA just says see educational documents, so they.
We don't, I have no idea what that education document is,
I don't either.
but we did a video instead, so I guess that's what it is. Okay. All right. Nope, must be we lost everybody that was out there joining us.
On the Mover app, it just says see educational, the New York app, it says 1 gram and 100 mL.
So I think we've covered most everything. But the RSI, we've had some agencies bring it to our attention, wanting to do that, and they wanted to talk about putting together a committee.
I think we've done that. We've had a committee, we've approved it, and we've left it up to discretion of the medical directors for individual agencies to approve or not approve RSI. The difficulty being you would need, it's a 2-agency thing because most of our agencies don't staff themselves with like 2 paramedics. It's a 2 paramedic
It is a
requirement,
requirement,
right?
requirement.
Yeah, that's where we had left it, and we're going a couple of years back now.
Right.
Yeah.
And so the next steps to be achieved were education, right? To do regional education to get paramedics up to speed to do this.
But again, I think if we had put it onto determination of the specific agency, we weren't requiring the region
Right.
to go RSI. It was like if the agency wants it and the doc approved it, the doc was going to bring it before this committee for recommendation. And the doc would have their training program and whatever they needed required, right?
All I remember was that you guys were requiring live tubes in the OR to be observed,
Right.
which is not allowed. You're not allowed as a paramedic to go to the OR and drop tubes unless you're in class.
So the
My
next,
understanding.
Okay,
the next things to be achieved were education.
right.
And then, finding a way for agencies to get their paramedics into the OR. Now, step 1 of that is just making a agreement with your hospital, which is achievable and we have achieved in many places. However, step 2 of that is how do we cover those paramedics as far as liability goes inside the hospital, do those two. And that is something that we had not.
I don't think you can.
Really
outside, of
negotiate.
course.
Well, let's not say no, right?
I know, we've,
So we've actually given some of the thought, I don't know, if Bruce, you want to talk about a workaround that we came up with. It will not, I don't think it has to be the only workaround that we've come up with, but. Do you
Yeah,
wanna
I mean,
talk
we've
about
developed a really great relationship with all the hospitals with our paramedic program. Andy Teague, who's our clinical coordinator, has really done a bang-up job meeting with these guys one-on-one, creating an environment where they understand what we're doing with our students before they even get there. You know, including our airway labs, our cadaver labs, and everything else. One of the ORs has even gone so far as taking and spending a 4-hour day with the students doing an OR orientation. So they walk in and, you know, looking at an anesthesia machine for the first time isn't foreign to them anymore. And so, you know, we have developed a great relationship with them. One of the things that we've talked about doing is a topic-specific refresher module, which we could get a course number from the state from, which would then make it that their students. They would be co-driving student liability program.
Existing insurance could go back if we're gonna observe.
As a refresher program.
Do they have to pay for this? I mean, how are they gonna?
Well, they would, I mean, because it's not something that would just, be able to pay for the OR. You know, we would still have to track the progress, and there would have to be some sort of didactic component to that. So we'd actually propose was like an 8-hour, airway lab, and then X amount of tubes within the OR as part of this refresher class. And, the state doesn't like to do standalone courses like this, but they've also said they wouldn't say no. So, I mean, it's something that we certainly could facilitate. And I think that our relationship with the hospitals has certainly been built enough that it would just be one more mechanism to do this. And I'm complex to all CBPH, AMC, Camp Potsdam, they've all been really awesome with us, so.
Have you worked with the anesthesia at CDPH?
Yeah, Lars,
director.
Yeah, he's been awesome, so.
And the anesthesia group at Glens Falls is pretty receptive to this, so it's just a case of the liability documentation.
Correct.
Exactly.
And this is the way to get.
around that.
To get paramedics back in
Yep.
under the student
Right.
fold of having
Yep.
them coming under, I think, liability.
Yep, makes sense.
So.
This is a proposal. It's the only proposal I've heard. I think that certainly there may be other ways to do this. But Bruce has been generous enough to spend some time
Yep.
trying to figure this out, and I think has a way to do it.
Good.
So the next step would be to put together that 8-hour day. For which I could use some help.
Well, and we'd actually talked about modeling after our airway day with our students. We break it up into sections on direct laryngoscopy, video laryngoscopy, surgical airways, lower gastric, nasogastric tubes, needle decompressions, all of those things. So there would be a full 8-hour day of that, and then X amount of tubes in the OR, and they would get their course completions. And then they can take that to their medical director and say, hey, I want to do RSI now.
How many tubes are we thinking they need to have in the OR?
10 per year is what we decided on last time.
10 per year?
Yes,
Go for training, to be certified.
to continue to be certified.
How about to be certified? To become,
10 the first year and 10 every year thereafter.
each student is getting 10 done before they get their certificate.
Well, I mean, that number's up to you guys.
That was the year that was the number that we.
I mean, that is what our medic students do to get through. We're finding that, the ORs can accommodate that couple of shifts. They're busy enough that after 2, 3, 4 shifts, they're accomplishing all of that. So, I mean, what you guys would look at requirement for that, that's up to you. We could just help facilitate it from that point forward.
And in-field intubations would count as your annual requirement.
Yep,
So,
they
yeah.
would count into that 10. That's what I recall us talking.
Yep, I think that's how I remember.
So if you did 2 documented in field
Yeah.
innovations,
You would need.
then you need 8.
So that could have to be right, you know, whatever it is,
Right, so then you're asking,
multiple times. a year.
paramedics would have to,
Because, like the age at Cambridge, we've been pulling all over to sit through almost all of that.
Right.
Right.
No, we
And what's that allow for any kind of, or lateral transfer of people who are already RSI actively in other regions? Because I'll be, like, this is so much more. I mean, I'm not disagreeing with it, I think it's great, but like, I'm credentialed the RSI in remote region. And the training standard is nowhere near this. This, I'm not saying it's unreasonable, but it is a significantly much more time.
what does it take to
undertaking.
maintain, once you're trained in RSI, what does REMO require you to stay?
It's agency specific. At my agency, I currently ride in. I do a scenario and drop a tube once a month. Under paramedic supervisor.
So that's 12.
Former agency I was at, I did quarterly training with tube scenarios.
Yeah.
Big trains for surgical airways. It was a quarterly thing, but still, it was agency specific.
Yeah, I think asking paramedics to go into the hospital, the OR, for 10 a year is tough, or 8, or however many they're lacking. Because it's gonna be a cost to do the education and, maybe something more in line with REMO where they're doing it in the agency supervised by paramedic or medical director, probably better method to state. I think that if you want to have that criteria as the initial, training and requirement to get certified, I think that's fine. But for continuing your continuing your certification, I think it might be just a bit onerous and very difficult, and expensive to do that.
Well, I guess this comes to, do we want to sit down and rehash all of this and vote on a different decision?
Can I add,
Do
can
we
I
want
maybe
to do
help
that
you out
today?
with
Do we
that?
want to do that at the next REMAC meeting? Because I will tell you right now, if it's not required to do 10 tubes per year, my vote is no.
Like in the OR,
In the OR, or if they can get 10 tubes in the field, I'm great for that.
Yeah, right.
But my vote is no. I will not support an RSI program if they're not doing it. I'll tell you that right up front now, and that will not change. Now that I do not need to be the deciding factor. That's why we're a committee. We're
Yeah.
not me.
So no policies, notes or anything came to me. So
We'll have to get the minutes.
I know,
right.
I don't even know when you approved it. I mean, I only have a small amount of past minutes. So it's either gotta be all rehashed or
Let's just get the
written-
minutes. We've
written
been through
down
this before.
or-
They should be done. Yeah.
we may. I gotta have an idea, but
We have
again,
to have minutes. There's no point in doing the meetings,
Right.
right?
Couldn't agree.
Yes, right.
I agree, but I am new to the position and didn't.
No,
get
I
any
understood exactly. I'm just talking on, previously.
Yeah.
We gotta have minutes. Yeah. I mean, I'm happy pushing this forward with our one final decision point in terms of how many of the specifics in terms of maintenance of credential. And we can discuss that, but in order to keep this actually moving forward,
I could.
I'm happy going
present-
with all the rest, right?
Bruce, would you see if you can get that course? And that way we have a little bit of movement.
Yeah.
That would be great.
Yeah.
I could find the policies from other regions, because I think Central New York does it, and bring them all forth. Or send them out for review. So you got Remo, North Country, Central New York, all have RSI.
I know that included in that discussion was this question about crossing lines.
Right.
I can't remember
I
what.
can't
was
remember where we
decided,
came
and I
from, and
apologize.
especially down our way, pretty much most of our paramedics are
Right.
in alternative agencies as well, who are already credentialed for this down in Remo, so, yeah.
Is a maintenance each year, is it acceptable to do simulation based intubations, or you really want live tubes?
We'll put that one specific issue up. Let's put that off to the next meeting. We can kind of approve all the rest. And just so we get time to get a little bit more information and where people are comfortable at. And in the end, we can also leave that up to medical director discretion of their agency, but we can kind of do everything else right to get this moving.
The curriculum's written. It
Okay,
was written
yeah,
2 years ago.
yeah, right. So,
The scenarios, the curriculum, everything's done.
yeah,
It was done back then.
gotcha.
So
So is there a specific motion or thing we need to approve at the
I'm
moment or
trying to
anything?
learn about it.
Yeah, okay.
You know, we had agencies within the Mountain Lakes region
Yeah.
come to one came to me,
Yep,
one
okay.
reached out to Zach, wanting to know about moving forward with the RSI within the region.
Okay.
And obviously, I
Okay.
don't know.
Well,
I'll
we're
put
ready
it
to
in the
move
region.
forward with that as we have been originally. And so then the agencies wanted to come with that. It comes through the medical director, can bring it up. I think where we had left it, does the medical director just bring it to this group just for a blessing?
and the QA/QI was going to be done by this group, at least initially.
Okay,
That was
and then
the
the
other part of that.
QA/QI, and then we'll talk about it, right? Okay,
Video learned, so just to review what I remember
Yep.
about this, video laryngoscopy was mandatory. The ability to feed that video from your video laryngoscope into the medical record was mandatory. And then this group was
Really?
going, yes, that was part of what we discussed. And this group was going to
do we have ability
review
to
each one of those.
accept that as a medical record? I know I can't.
To get the video into
To
the
the rec-
PCR.
Or to accompany it somehow. But this group was to review each one of those intubations as a
Yeah.
REMAC
Yeah.
for the initial.
I mean, it's easy enough to get the video file and review that. Whether or not you can get that into the medical record, I think is a different.
Oh,
question.
I think you're understand, like, I'm sorry. So not into the hospital medical record.
Okay,
I apologize.
into what?
Into somewhere where we can save it so this group can review it.
Oh, okay, yeah, okay. So
I should use better words. I'm
right, yeah,
sorry.
so
I didn't mean that.
save the files, the video
Right.
files, just for internal review.
Right.
Okay.
Yeah.
And then we delete them.
Right, I don't think
I
we
don't
addressed
think,
it.
yeah, I don't think we should keep those long-term.
And you're saying double paramedic?
Well,
Yeah,
that's a standard from, that's beyond ours, but yes, that's.
I know that some use, some regions use paramedic and then another qualified to intubate personnel.
But that's going away, whatever anyhow. So with, and we never approved to have an AEMT and a paramedic do this.
correct.
So we had always said 2 paramedic, because it's one doing meds, one doing the intubation. And since the AEMT ability to intubate is going away, it's a moot point. So
Right,
it's
well,
two
we have
paramedics.
critical cares.
Discussion at one point, way back in, when this first came up, was could you use a CCT for the tube and a medic for the drugs? Because there are still active CCTs, but I do know a lot of our CCTs is bridged, but that was part of the original discussion.
Yeah, the critical care techs were in there at that time, so that's what.
But
changed.
all of the reasons I'm not bringing it as double medic, but the
Yeah.
other reason I meant out on their CCT.
I think the way we decided to do that was, at least initially for the rollout, we would use 2 paramedics and then we would come back to it after we had launched a program and decide whether we wanted to incorporate CCs after that.
Mhm.
That way it's a smaller group for us to control for
Yeah.
and fix problems with. And then if we needed to expand it, we would expand it. That's what I recall.
So what's the motion?
The motion is to ask Bruce to get a course approved so that we can cover the liability to start RSI. And if there's any other takers that want another workaround, please, I don't want to make this into the, particularly because I have a vested interest in the ECH program. I don't want this to feel like this is a monopolized thing, right? If there's another workaround, it's certainly welcome.
Sure, yeah, make it as safe but efficient.
So was there a committee, like, I'll find the minutes on the discussion, but where's the education, who's kind of heading up,
It's all sitting on my computer waiting to go.
Okay.
I can send it on over to you.
I really want it, but I gotta build a policy. I'm assuming, did anything go out to regional agencies? I guess that's my next question. Has there been any communication?
I think everybody was stuck on how to facilitate the 10 live education.
Okay,
This is
Yeah.
great.
Well, it was right before COVID, so I think we got.
Yeah, maybe that's what it's right. Yeah.
so I think we'll have to develop how we're gonna put that out as well and then bring it back, so.
I think we need to discuss continuation. I think I'm on board with the initial training and requirements for the OR and the 10 intubations. I think that's fine. I think, going forward, I think we should talk about maintenance of certification. And then QA, make sure we have a QA process. And then, sort out, what the procedure is gonna be, who's gonna do it. And one of the biggest things that worries me about pre-hospital intubation is just that decision making. So I think that's one of the, not just that, we can train anybody to do the skill, like, that's why I'm not so sure OR is necessary, but it's the decision making. So I have a lot of paramedics that I would not trust to intubate, not because of the mechanical skills, because of the decision making. But that's what I would be most, interested and concerned about focusing on is the decision making behind, the actual procedure rather than the mechanical skills required to put a tube in. I think, all of that, I think.
My
is a
thought
discussion.
is, my thought about RSI is, as a region, we should have single digit RSIs per year.
Yeah.
If we're moving into the 10 or more for the region, we're doing too many.
Mhm.
Now, as we get our feet wet, we're gonna need to do too many to learn. However, new end game, how many airways can we each think of that needed an RSI? Not, it was more convenient, but this was the only way you're going to maintain that airway.
Mhm.
And it's not many. So it should never be any, but the truth of the matter is that we don't play the short end of the odds in our profession, right? When it's that airway that you cannot get any other way, and you don't have RSI, that's not okay, and that's what we would like to fix, so. They should be rare.
And then the other question would be reciprocity in terms of for medics who are already qualified for this and out of region.
Yeah.
Well, yeah, right.
Yeah, say, because North Country has there's only like 3 agencies in the whole region
Yeah.
that move forward with that.
Right.
The Guilfoyle.
Well, certainly I can see, like, if your agency medical director that you're working with today has not approved RSI, then you're not going to do it for that agency, right? But you
Sure.
do it for your other agency.
Right.
Okay, fine, but
Right.
the cross-border with Remo is really gonna be down to what you guys want to do there.
And do we leave, we could, and I'm happy, we could leave that up to medical director discretion, or do we need to advance that as a definitive, a unified way of granting reciprocity, which may be
We
difficult?
probably should decide on that as a region.
Yeah, I think regional, and then you can add on,
It's gonna
so
be
if we have a
difficult if
regional
we're not
policy,
going
then
to.
you bring someone in and you say, I want to personally watch you do X amount of intubation, I think that's fine, but I think there does need to be some standard, some floor that the region sets that you can go above if you want, but at least have some sort of standard where the region says, this is what we need to, satisfy whatever reciprocity agreement we have.
So if you put that on for new business as well, if you haven't already. Reciprocity from other regions.
So I think we can also talk about so I don't. We'll just back it down a little bit, reciprocity for continuing medical education requirements between regions. I don't know what Remo's requirements are. I know that North Country, theirs are fairly similar to Mountain Lakes, although they do it twice a year versus once, so I don't think, they're still done annually. I know a while ago, North Country had sent a reciprocal agreement over, so our providers didn't have to do CMEs in Mountain Lakes and in North Country if they worked in the agency, that they would accept each other's. If there was a QI issue, it would go back to the REMAC of the agency they were operating in, so like Saranac, they were in Saranac Lake, it was an issue, it'd go to Saranac, it would come here if there was a QI issue. If they were in, Potsdam, it would go to, North Country if there was a QA issue. So wherever the agency of origin is. So is that something that this group would be willing to move forward to help with our at least with North Country? I don't know what Remo's requirements for skills are.
So what are,
I mean, like end of year kind of stuff.
Yeah.
I tell you, it's agency dependent and changes every year based on where I've worked.
So we have a standard where
So much fun.
they're done via scenario, but they have to do all their skills. So it may not be just running one full code, but they have to do multiple scenarios to finish them, but you have all, your defibrillation, your cardioversion, your pacing, for the paramedics, your crike,
can you
med
send,
administration.
can you send that to us and we can look at it?
I will.
Okay.
I just figured I would bring it up. I can put it on the next new agenda.
Yeah, I think we need to be able to,
I mean, we'll be past the new year, so this, our providers still have credential at the end of the year. I figured one thing at a time was enough.
yeah, I
I
think,
did the minimum
this is
equipment.
my
this time.
opinion, that this year, we're like, there's already the expectation of what we need to do. We'll send that to you guys to stay online for this year, and then that can be on the new business. for-
Yeah, well, it wouldn't change it would just say that you as a REMAC in a region accept the North Country skills for providers that may do their skills in the North Country.
Okay,
It's not changing the skills. And then that you guys would accept a provider into an agency that did the skills in the North Country or continue. continue on. It's just a reciprocal agreement. Not changing anything. We hold one with Mid-State in Central New York right now. So, but I'll send that out to the next one.
So I would still think that the person would need to be approved by the medical director, correct?
Well, yeah, I mean, they gotta be approved by the medical
Yeah.
director, but I'm
I
talking
guess
about
on Yahoo, it
year-end
goes from region
skills.
to region to region
Right.
all the time.
This is just year-end skills. So if I'm a provider and I have one that's in
Yeah, no,
Saranac
that's
Lake
reasonable, right, it's
in
being
Messina,
formally
no.
done, yes.
excuse me, Tri-Town.
Right, well, yeah.
If they do their skills in one region, it's good in the other and vice versa. So that's all the agreement on that, not changing skills.
Right, does anybody have anything else? It's a long one, thank you, guys. Motion to adjourn,
Second.
all opposed. Thanks, everyone.